You're good.
That's good. Can they hear everything? Could they before?
Yeah.
Okay, let's try that all over again. So we are talking about the endometrial receptivity array. Sorry, there was no sound apparently initially. I am your host, Dr. Rahi Victory. So endometrial receptivity array is a test designed to determine if the lining of your uterus is ready for an embryo to implant. It measures the level of genes and the activation of those genes. And so originally when they promoted this, this was supposed to be the cure for everything, solve all the problems, fix everything that was out there as far as failed embryo transfers and so on. And so I fell for it completely. I absolutely went into it and I very quickly realized this doesn't work at all. Like there's something wrong. I even had a guy come out to us all the way from Spain because that's where it was originated to show us how to do it because I thought maybe I'm doing it wrong. And sure enough, I wasn't doing it wrong. It just doesn't work. So we have had multiple studies now, all of which have shown that it doesn't work, including the test sponsored by iGenomics, which is the company that owns the ERA. And so their own test showed no benefit. There was no benefit to doing the ERA test. So another randomized controlled trial was run by an author by the name of Doyle, and it was published in JAMA, the Journal of the American Medical Association. Big journal. If you're in JAMA, you're the you know what, right? Like you've made it. You have hit the holy grail of publication. So they published, excuse me, in JAMA and demonstrated again that there was no difference between the two groups. Now it's important to understand that study to understand what the next person did because that's really critical. So in the Doyle study, they took a whole population of patients. Everybody got an endometrial receptivity array test. So, whatever number of people there were, they all did the test. Everybody. Okay. I think it was around 500 something. They all did the test. In half of the people that did the test, they then followed what the test did and demonstrated so that half of the group actually followed the results. And if it said you were early, they went later. And if you were late, they went earlier and so on. Or if you were receptive, they went ahead. And in the other half of the group, they still got the ERA test, but they ignored it and they did all the embryo transfers on day 5. So between those two groups, you would think that if the endometrial receptivity array has a significant benefit, then in the group that's getting the personalized transfer, they're going to do better. But they did. They got the exact same result as the group that everybody did at day 5 after 5 days of progesterone embryo transfer. So they said, okay, there's no difference with this test. But what Kevin Richter, is a really brilliant American REI, did, he took their data and said, wait a second, you guys actually missed the whole value of your study. Let's go back and look at the group that did the ERA test, but ignored the results and just transferred everybody on day 5. What were the results of the ERA test? Because in that group, everybody got a day 5 embryo transfer, but some people would have been pre-receptive, some people would have been post-receptive, some people would have been receptive. And you would think that between the people that were non-receptive, so they all did an ERA test, but they got a day 5 transfer. So between the people that were not receptive, either early or late, and the people that were receptive, you should have seen a difference if the ERA test actually detects a difference, right? So everybody got the test. You didn't follow the results. You just went ahead and transferred everybody on day 5. But if the ERA test works and you're supposed to be transferred on day 6 or you're supposed to be transferred on day 7 or whatever the case is, then for those people that actually tested outside of the range but didn't even know it because they weren't in the group where they were following it, then those people should have done poorly and they should not have succeeded. But even within that group, there was no difference in success except that there was a 13% decrease in success in the group that had the ERA test when they analyzed it by what they would have done had they shifted the window of implantation. So there's two really important things to learn from that. Number one, The error test doesn't work because it can't differentiate receptive from non-receptive. Everybody had the test. Half the people, or whatever number, ended up with a receptive result. Half the people probably didn't. But within that group where they all got a day 5 transfer, they had the same outcome, which means the error test is incapable of detecting a difference. It actually can't detect the difference. And then the second part is it's actually harmful. So when they did their calculations, they showed that there is a 13% decrease in success. So for all those of you who think the error test was what made it click for you, unfortunately, and this is not controversial, this is just the truth, it wasn't the error test. You just tried one more time and it all clicked. It has nothing to do with the error test. The error test is incapable of even detecting if you're receptive or not. And basically, igenomics barely ever even talks about that test now. It's buried under the endometrio where they're doing Emma Alice and they throw in an error test for you as well. But anybody following the error results is actually decreasing their success rates. So that is why my number one thing from 2023 was that Kevin Richter reanalysis of the Doyle study, because it was pure genius. He figured it out. He looked at the data and he clearly showed that not only is it useless, it's harmful. So for God's sakes, if your fertility specialist is telling you to do the ERA, ask them if they've read that study, because I guarantee you they have not. Anyways, that was my rant for tonight. And that explains why we had our post today. And you can probably post that up again if you want to for people. And we're going to take questions now. So if you have anything you want to know about, don't hesitate. Please try to refrain from asking questions about what your success rate will be with whatever, because I can't answer those questions unless I know every single detail about you. But happy to answer any other questions that you've got. I'm assuming there's 10 million already.
There's something like that.
Yeah.
How important is it to actually diagnose and treat endo after several failed IVF? RE doesn't want to, since it said it'll be several years before it can be done.
What? Why would it be several years before it can be done? So how important is it? In my opinion, critical. If you failed several embryo transfers, you need to find a reason. So it's going to be inflammatory, of which endo is part of, or it's going to be infectious, or it's going to be a sperm DNA fragmentation problem, or thrombophilia, or something, or progesterone level, or thyroid, or vitamins, or whatever the case is, structural abnormality, but you need a reason. And looking for endo should be on the list. And even in Canada, it doesn't take years, it takes months. So I don't know what they're talking about. That's absurd, like completely absurd. In what country does it take years to find out if you've got endo? Definitely not even in Canada. It does not take years. If they're telling you that, they just want you to keep doing IVF because that's all money, money, money.
Hey, Dr. Green Tea, in terms of high vitamin B levels leading to autism in babies, is
Yeah.
it the high vitamin B level at the retrieval stage or after the transfer that really leads to the autism?
So the study on that was a long time ago, so forgive me if I'm misquoting this, but the levels were 17 times the normal upper limit of B12 to cause a problem with autism. So you've got to be on a ridiculous amount of B12 for that to happen, number one. And number two, it was done for people who were pregnant. It wasn't fertility related. So we don't know if it's pre-pregnancy at egg retrieval or embryo transfer, but in theory, it's during the pregnancy because that's what they analyzed. So yeah, I mean, there's no question that it could be a risk factor, but you got to be on stratospheric levels of folate and B12 for that to happen. And I've never seen someone that has high enough levels to justify even close to being 17 times normal. And if your levels are 17 times normal, you're either overdosing on it or there's something wrong with your physiology.
My BMI is over 30. Is it okay for me to go on a weight loss plan with diet and exercise while trying to conceive? Or should I wait until I've reached my goal? I'm currently attending a fertility clinic.
Depends on what you're doing, in my opinion, and how old you are. So the studies say if you're less than 38 and you can achieve significant weight loss, that you should go ahead and lose the weight. If you are over 38, you should go ahead with fertility treatment unless you can achieve a massive amount of weight loss very quickly, because the compromise coming from your age outweighs the benefit of losing the weight. So that's generally what we tell our patients, unless their BMI is over 40. Over 40, it's actually dangerous to get pregnant, so we don't encourage people to do that regardless of their age. But if your BMI is in the 30s, I mean, yeah, I would take the time to try and lose the weight as long as you're less than 38 years of age. And you still have time, and studies show that it doesn't negatively impact your success. There's a huge Chinese study. We have reviewed it on Fertility Factor Fiction. That was probably 2 years ago now, or even longer. But yeah, I mean, the age is critical, and the amount of weight you can lose is critical. So if you're going to go from a BMI of 30 to 29, sure, it's going to help a tiny bit, but not enough to make a big difference. But if you're going from 30 to 26, you are going to make a very substantial difference. And that's something you should consider doing.
Increase the gain a little bit.
That would be a good thing. What's that?
We'll find out. I'll do this if you need to tweak it more.
Okay. I think that's the right button.
Yeah, sorry.
Unless is it this one?
No, that's me.
It's that one. Okay. Yep.
I plan on stopping isotretinoin soon. Isotretinoin soon, so that I can start trying to conceive again. I'm 36. Also, isotretinoin seems to calm my period pain. Any thoughts on why that might be? Not that I'm complaining.
I've never heard of isotretinoin calming period pain. That's fascinating. Isotretinoin is derived from high dose very active vitamin A, and high dose vitamin A is known to be a teratogen, and isotretinoin is extremely teratogenic, so meaning it causes the baby to become structurally abnormal. So you cannot use it anytime around trying to conceive. So I don't know why it would quell your period pain. I've never heard of that before. Interesting point of study, but I've never heard of that. Interesting.
Do you recommend valacyclovir for EBV before transfer?
We do. So if you have Epstein-Barr virus, the only thing you can use is valacyclovir, Valtrex, or acyclovir. We don't know of anything else that's useful. Granted, there are no good studies to show that that's beneficial, but we do still do it for our patients.
I had laparoscopy and no endo found, but surgeon found endosalpingnosis.
Salpingiosis. Yeah.
What is the impact of that, but no endometriosis?
Endosalpingiosis is kind of like tubal endo, but of a different variety. So when you get that, it makes it more difficult for the egg to travel through the tube. It's primarily thought to be an inflammatory problem, and again, reduces your fertility. And some people say it increases your risk of ectopic pregnancy. So those are the risks with having endosalpingiosis. I'm not aware of any specific treatments that treat it, because you actually have to kind of biopsy it to know that you have endosalpingiosis. So no one's biopsying tubes. Like, it's so harmful to the tube. We just don't do that.
A little bit more.
Okay.
Yeah, that would be good for sure.
So full disclosure, Tarek and I raced to start the show because he bought way too much Turkish food, and we were picking out right before the show.
Sure.
Yeah. And then he bit off half a jalapeno, and I thought he was going to die, but
I almost died.
it looked painful.
Yes. Oh,
that was a good one.
What tests do you recommend for recurring implantation failures?
Thorough analysis of the sperm, analysis of you. What are your personal habits? What are his personal habits? Smoking, drinking, drug use. What is your body mass index? Look at your vitamins. Check all of your hormones again, especially your thyroid and thyroid antibodies. Thrombophilia screen. And we're big believers in the Fertility test. So we order a combo of the immune test that they have, as well as their uterine microbiome and vaginal microbiome test. So it's combined together for us. And then in some cases, if there's any indication, a laparoscopy for endo is very reasonable to consider.
If my partner or myself get the flu or COVID, is it still safe to try to conceive this cycle? And or is there anything I should add to my protocol to help because of this?
If you get sick or you have COVID, we tell you to wait a minimum of 2 months, especially with COVID. If you are trying on your own, that's fine. You can go ahead and try. But if you're doing IVF, I would not ever do that right around the time you've gotten COVID. It won't work. And the article we shared with you guys last week, which was really cool, was the systemic inflammatory infertility index or infertility inflammation index. So it was basically a calculation from your complete blood count where you include your platelets, your lymphocytes, and your neutrophils. It was neutrophils divided by lymphocytes in brackets multiplied by platelet level. And if you were over a certain threshold, which was roughly 630, then they they suggested that your chances of success were decreased. In particular, if you were in the highest quartile, there were very significant decreases in success. So for anyone that's sick, you can assume that you're going to fail that test, like it as a prediction model. And so you are going to end up with reduced chances. Does that mean it won't work? No. I mean, most of the numbers we were looking at in last week's show were like 50% reduced, 30% reduced. I think the highest was like 60% reduced and so on. So you still have a 40%, 70%, 50%, whatever the numbers are, chance of success. But would I want to reduce my chances? No, I just wait a month. It's not important to rush into fertility. We say this on the show almost every week. I don't think we said it last week, but I will say it again this time. Rushing fertility is a really good way of making your fertility clinic rich and making you very poor. Don't rush your fertility. There's no indication to do that. Even if you have diminished ovarian reserve, they have shown that a 6-month delay makes absolutely zero difference in your outcome. So do not feel pressured into doing something because your fertility center told you to do it. You don't need to rush. The one and only exception to that is guys with testicular failure where they need to freeze sperm. But as long as they freeze sperm, they can still wait. So, guys with testicular failure, you're going to stop making sperm. And I can't turn that clock backwards. Like that doesn't work. So you don't have time. But women, even with diminished ovarian reserve, it's not like if your AMH is 3 this month, all of a sudden next month you stop making eggs. It doesn't work like that.
Dr. V, what supplements do you recommend for men with a normal SA?
Just a daily multivitamin. I mean, if you've got a normal SA, you don't really have to do very much, but a normal SA would have to include normal DNA fragmentation. So a multivitamin will probably take care of most of that. If you want to do something more, there are multiple male fertility supplements available. Just to name some, I'm not recommending anyone in particular. ProFertile, Fertile Pro, NFH has one. Pacific Coast, I think it's called, has one. Theralogics has one now for guys. There's all sorts of different vitamin brands out there. Elan has one. So it depends on what you want.
Sorry.
Typing. I rarely see you typing in the middle of this show.
Once in a while. Can you develop endo after having 3 kids with PCOS? Should 3 rounds of IUI work? If it doesn't, does it mean I have something else wrong? P.S. It looks like peanut butter on the wall behind you.
That's glue from where the car fell down. And I tried to re-glue it today. And despite a valiant effort, it absolutely failed. I literally had one of my junior employees stand there for 10 minutes holding the bloody thing to the wall. Poor guy. He was quite distressed by it all. Yeah, I need a new car and I need to fix it. So I might have to look for a 718 Spider RS or something to replace the convertible Ferrari there. In any event, failing 3 cycles of IUI does not mean there's something else wrong. So depending on your diagnosis, which you mentioned is PCOS, your body mass index, the quality of the sperm, your age, all of those things, it's entirely possible that you would fail. Remember that even after 6 cycles of Clomid and IUI or letrozole and IUI, your chances of success are a live birth rate of 30%. So it's not unheard of to fail. Like that's common actually, and lots of people will not succeed and need to move on to something more aggressive or additional testing. So that's not indicative that there's something else wrong with you. It's just IUI doesn't work that well. What was the other part of that question?
3 rounds of IOI.
Yeah.
Can you develop endo after having 3 kids?
Oh yeah, can you end up developing endo? You can develop endo at any time. Certainly, it would be unlikely after 3 kids, but it's possible.
I got a positive today, 11 DPO, but my temp dipped big time, and now I'm bleeding slightly.
Take progesterone. Talk to your RE about taking progesterone.
Can adenomyosis cause miscarriages?
Yes, no question. Actually, I was going to review a study tonight, but it wasn't quite strong enough. Maybe we should. It's about the contractility of adenomyosis. They did this awesome study in Europe, I think, where they analyzed, it was Europe or China, but I think it was Europe, where they analyzed the contractility and a whole bunch of different characteristics on ultrasound of women with adenomyosis versus normal women. And they showed that the women with adenomyosis had way more contractions in the uterus and more intense contractions in the uterus than women that didn't have adenomyosis, which would clearly explain why it doesn't work as well in adenomyotic women and would certainly increase your miscarriage rate as well. So very interesting data. Maybe we will review that next time.
My sister-in-law had 2 miscarriages. Her second was a lot worse. We're nervous she can't conceive. She's 38 years old.
There's no question there.
Nervous.
If you're nervous, go see an RE. I mean, make sure she sees a reproductive endocrinology specialist so we can figure out if there's a problem or not.
Hello, is there a reason you normally recommend Lupron over Orilissa for suppression?
There's no evidence, and I looked it up yesterday again. Zero evidence that Orilissa is beneficial for an FET. None. It doesn't exist. So I can't tell you if it works or not. It might be the best thing ever. It might be better than Lupron. I can't validate that, so I'm not going to be using it unless I can turn to a study or rationalize it. And rationally speaking, Orilissa keeps your estrogen levels in the mid-follicular phase. So it's higher than a baseline, whereas Lupron keeps your estrogen levels very, very low. And the whole point of suppression is to get your estrogen levels low. So it couldn't biologically be better. It doesn't make sense.
I'm going to fast forward to a question just because it's from far away.
Oh, okay, sure.
Hello, good people.
Good people. Wow. Where is it from?
I'm about to that.
Oh, okay. All right.
Can you please make a video
Yeah.
about the importance of vitamin D before the start of IVF and during pregnancy? What values in nanograms per mil should be? Greetings from Bosnia and Herzegovina.
Herzegovina.
Yeah.
Wow. Well, hello from Bosnia. Yeah. I'm used to nanomoles per liter for vitamin D. I'd have to do the conversion, but in nanomoles per liter, we want you minimum over 75. So 75 up to 250 is considered normal. As far as make a video about it, sure, that's an easy one. We can do a video about it.
Definitely.
Do we have one on vitamin D?
It'll be within the vitamin ones and the natural treatments.
I don't know.
It could be buried in that. I don't know if we actually did specifically vitamin D.
I've done posts on vitamin. If you scroll back in our Instagram, way back, like 4 years back, one of our early ones has like I remember it was like a video of a sunshine, because I figured that made sense, and it talks about vitamin D, but it was just a post. I don't think we have a video on it.
We should do one.
Do a video on vitamin D.
Yeah.
Write it down somewhere so we remember. Okay.
Can you find endo by any other way than lab, 3D ultrasound tests, anything like that?
Nope. Well, you can find cysts of endometriosis on ultrasound or MRI, but you cannot detect endo in any other way. People talk about it all the time, receptiva, this test, that test. the sliding sign on ultrasound, blah, blah, blah. It's all nonsense. You can't detect endo unless you go look at it and biopsy it. I actually laugh at all those various tests people claim they can do. You can't see endo without,
One of the first things I learned
yeah.
was we did that video about endo, and the thing was that you can't test endo unless you go in there and check it out. I remember that. That was day one fertility factor fiction.
You know, this is really good tea. It's like a peach ginger, it's like a spicy peach tea.
You know, you actually have a question about tea as well. It's not there yet, though, but it's on the way. It's on the way. Um, can you touch on RPL, things in your opinion to look into?
We did earlier in the show, but thrombophilia, infection, inflammation, vitamin levels, thyroid function, sperm DNA fragmentation, BMI, hormone levels, and shape of your uterus through saline infusions on Instagram, DNA fragmentation, smoking, drinking, drug use.
What dose of melatonin do you recommend?
3 milligrams a day.
What are your thoughts on day 7 embryos, untested, 30 years old, only embryo we've ever made after 4 rounds?
If you look at the studies, they in general suggest that untested day 7 has a 15% chance of success. Even a euploid day 7 has a much lower chance than a euploid day 5 or day 6. So I'm sorry, I don't have great results for you, but that's what the research shows.
When should people see a reproductive immunologist?
Well, you should see a reproductive immunologist if your reproductive endocrinologist doesn't know enough about reproductive immunology, which arguably we should. So I try. But yeah, I mean, recurrent failures, recurrent miscarriages that are, extreme, or you have a reproductive endocrinologist that's unwilling to listen. In that case, switch to one that is probably my opinion. You don't necessarily have to see a reproductive immunologist. I guess the other category would be people that have known issues with inflammatory conditions, arthritis, lupus, stuff like that. There's certainly no harm in seeing an RE that specializes in RI because we know what we're doing.
Should I be using 10 milligrams of melatonin or just 3 milligrams or 6 milligrams?
Just the 3.
Hi, can you please repeat the ratio you mentioned earlier for inflammation?
Oh, it's part of the study we reviewed last week on our show. So the calculation was the platelet count multiplied by, and then in brackets, your neutrophil count divided by your lymphocyte count. So you have to divide your neutrophil count by your lymphocyte count first, and then you multiply that times your platelet count. And then the quartiles were in 600. So it was like 628, if I remember correctly. So it was like 628, 1260 roughly, and then 1920, and then off into the 2400s, 2500s. So the group that was in the 2500s, which had the highest amount of numbers there, showed the highest amount of decrease in success. So they said that is risky. And because of that, if you do have this very easy prediction test, you can actually predict how low a chance you have. So that validated everything I've been saying for 4 years about not transferring around COVID, because lots of people were saying, oh, it's fine. And I kept saying, no, it makes absolutely no sense. And sure enough, this study validates that if you're inflamed, if your immune system is activated, you're going to have a lower chance of success. And it's so easy to test. The CBC is pennies and can be done in seconds. You get your answer quickly and easily. And, if you do it during your FET cycle, you'll know ahead of time.
Conceived twice normally with endometriomas.
Oh, wow.
1.6 centimeters. Trying for the third.
Those are small.
For 4 years, no success. Is it endo?
Crystal ball question, so hard for me to answer. I would need to know so much more about you. Unlikely if you previously succeeded twice, and those are really small endometriomas, but I would need to know more about you. I can't answer those questions without knowing all the details. Sorry.
Thoughts?
Okay.
No,
Okay.
PCOS,
Okay.
DOR,
Oh boy.
plan.
Those two don't go
I
together.
know, I
Yeah.
know. Plan to embryo bank with IVF layer, the capital protocol, then down regulation.
D capital.
Cap, eptal,
Oh,
decapeptyl,
decapeptyl. Okay.
decapeptyl,
Yeah. 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 Yeah.
then regulation, then
Is
down
there a
regulation.
question or she's just suggesting
Your
that?
thoughts
My
on that?
thoughts. So decapeptyl microdose flare, we tried it. It did not work well at all. So we stopped doing it almost immediately. It was terrible, actually. I don't know why it should work the same. It just wasn't working. So that's number one. That's just our experience. I can't tell you what to do. With regards to PCOS and DOR, those can never go together. So no one with PCOS has DOR. By definition, when you have PCOS, you have super high performing ovaries. Nobody with PCOS gets DOR. So somebody's misdiagnosing you. And then as far as doing embryo banking, I mean, if you have DOR, embryo banking is reasonable, but you got to do the math. So I spent half of this week, literally, trying to communicate, even today, half of today, trying to communicate to people to explain embryo math. So this isn't self promotion, but I genuinely think it's a really good video. Our video on embryo math on YouTube is really very, very useful. So you need to watch that to understand what your chances actually are. Because people we know from research hear the doctor say something and take something completely away from it. So something completely different away from it. So again, there was this great study done in Israel where they took older women who went in to a fertility clinic and they said, you have a 5% chance of success. Explained it to them, went through the numbers, blah, blah, blah. Everybody was told the same thing. You got a 5% chance of success. As they were exiting the clinic, following the appointment where they were told this devastating news, they were told to fill out a questionnaire. And part of the questionnaire said, what do you think your chances of success are? And the average chance of success was 49.3%. So keep in mind, they were told their chance is 5. And they actually took away from it that it was almost 50, 10 times higher than it actually is. So when you're dealing with DOR, what you need to understand is you need a lot of eggs to succeed. Okay. Most women with DOR are going to be older. So genetics comes into play. The number of eggs you produce comes into play. And then depending on which author and study you believe in, and there was a debate about this at ASRM this year, the genetics of embryos from women with DOR may or may not be worse than same age women. So in other words, if you're 35, roughly 50% of your embryos are abnormal if you're a normal, healthy woman. But some people, myself included, believe that if you're 35 with DOR and your DOR is making your ovary act like you're 40, you're going to have an 80% chance of an aneuploid or genetically abnormal embryo. So before you jump into embryo banking, you got to understand that you may need to do this multiple times to succeed. So as an example, I had a chat with a 45-year-old woman who is very keen to proceed and do IVF, but I had to explain to her that at 45, over 90% of your embryos on day 5 are genetically abnormal. Here's a really good, easy example of embryo math. So in order for me to get you one genetically normal embryo, which by the way, does not function the same way as a 35-year-old genetically normal embryo, to get you one genetically normal embryo at 45, you're going to need to make me 10 day 5 embryos. To make me 10 day 5 embryos in our lab, I need you to give me about 16 fertilized eggs. And that's a really good success rate for blastulation, right? Maybe 15, but we've got a super high rate, about 70% of our embryos reach blast. Some places are as low as 30, so you need way more. But in our clinic, let's say 15 fertilized eggs. And in order to get 15 fertilized eggs, you probably need to start with 16 or 17. And again, in some clinics, much more if their ICSI program is not amazing. So overall, you're talking 15 to 20 eggs to get one, hopefully, genetically normal embryo, which then at 45 only has about a 30 to 40% chance of becoming a baby. So you got to have your RE explain this to you, because what most REs do is just say, oh yeah, you need IVF, it's your only chance. And then people get suckered into it and it doesn't work and they go, don't worry, we'll try again. Yeah, but if you don't know ahead of time that you are only making 4 eggs and you need 20, so you actually need 5 cycles of IVF to even come close, then we're doing a huge disservice to you. I was interviewed by CBC this morning, CBC Radio this morning, and that was one of the topics of discussion. And we do a crappy job of educating people. We really do. Like, I try very, very hard. It's why we have the show. It's why I tell everybody everything honestly when I talk to them. It's why I'm extremely honest about presenting results. And it's why we made embryo math, so you actually know what it's going to take to succeed. But as a general profession, fertility specialists, we're terrible at educating people. We need to do way better, because people don't know that they can't freeze eggs when they're 40. I keep getting asked that. I want to freeze my eggs, I'm 40. You need 60 eggs. Like, we're just not getting that message out there, and we need to do a better job. So that's on us. I try with this show, and I appreciate you guys watching, and hopefully you'll continue growing our program so more people know. But at the end of the day, we need to do a better job, and we need more time for outreach and more resources to do outreach. But it's kind of hard when I'm here doing this 24/7. I actually suggested to the office that I go around and do a talk on egg freezing, and they immediately shut me down and
No way.
they said, Carrie's doing it, not you. Although part of that was because I'm a dude and she's a chick, but they shut it down immediately. They said, no way, you do not have the time. There are too many people to manage. Like this, I can't get out there to do the messaging. Yeah. I was at CBC at 7:30 in the morning.
It's early morning job. Yeah.
It was cool. It was good. Good interview.
What's going on with Cooper surgical lawsuit? Was your clinic affected?
I haven't even heard about a Cooper surgical lawsuit. Can you give us more details? That's interesting. I'll have to find out.
Yeah, that'll be a story. What test do you recommend for recurring implantation failure?
I've answered that like 3 times.
Okay. I'm preparing for an FET this month. I downregulated with Lupron for 2 months. I found out today my funded IVF cycle is set for March.
Okay.
I don't know what to do. Any advice?
She downregulated for 2 months. She started Lupron when?
IVF cycle set for March. I don't know what to do. I'm preparing for an FET this month.
No.
I downregulated with Lupron for 2 months. And I found out today my funded IVF cycle is for March.
I need more details. Are you talking your FET? Are you talking your IVF retrieval? I need more details on that one.
Should a patient with small lupus antibodies use prednisone during?
Oh God, yes. Aspirin, heparin, steroids, probably intralipids.
It says during GET. Is that
no, they meant FET.
FET. FET, yeah. Any updates on the wait time for laparoscopic surgery? Have been on the waiting list since August, and I'm not getting any younger.
Wow. Nope. So I just got my schedule for February, and I currently have 2, maybe 3 days in all of February. So I don't know what's going on, but I need to yell at somebody, so I will.
Is it good to drink raspberry leaf tea during an FET cycle?
No, stop.
If yes, how many cups?
No.
And what about decaffeinated black tea?
No. Don't drink decaffeinated anything, because you're better off just drinking the caffeine. The chemical processing used to decaffeinate stuff is not good. And don't drink red raspberry tea. It's got all sorts of prostaglandins and all sorts of other things in it that you do not want to take when you're trying to conceive. Avoid red raspberry leaf tea.
Really?
Yeah.
Interesting.
Yeah.
There's a huge shortage on HGH in the US.
Oh.
My doctor doesn't recommend an alternative med to Omni. Should I delay my cycle? DOR, 39 years old.
There is an alternative. It's called Saizen, Saizen. I think it's available in the US, so you can probably try that. But should you delay? The data on human growth hormone is questionable. The meta-analysis, which we did review on the show 2 years ago, a year and a half ago, something like that, showed an increase in number of eggs, an increase in the number of mature eggs, and an increase in the number of good quality blastocysts, but no increase in live birth. So it's hard to know if it's all that valuable or not. We do use it because I can't see how all those other things could be there and you wouldn't end up with a higher live birth rate. But the studies didn't show that. So, I mean, if it's going to be months, I would probably go ahead. Just use testosterone priming instead, but which does many of the same things. But if it's going to be a month or you can get Sison, I would just switch to Sison or wait a little bit.
How many days prior should day 6 embryos start PIO before FET?
6.
How do you diagnose and treat endometritis?
We use Fertility. So there's 2 ways to diagnose endometritis. One, which is useless, is to do an endometrial biopsy, send it to a pathologist who will not agree with the guy next to him, or the guy next to him, or the guy next to him. And so you don't actually know if you have endometritis or not. The second is to actually look for the DNA or RNA of the bacteria in your uterus. And for that, you need PCR. So there are a couple of companies that offer that. I don't know about the other ones just because I've never bothered to look. We use Fertility. No relationship with them. I'm not recommending them over anyone else, but that's who we use.
Yeah, just so you know. What do you consider
I wasn't
success?
sure if that gesture that you just made,
Good gesture.
no, was the pepper.
No, pepper's gone.
And you were still.
No. Pepper is done.
Tarek made a face, and I didn't know if he was suffering from indigestion or he was saying we have a lot of questions.
You have a lot of questions.
A lot of questions.
You have a lot of questions.
Okay, all right.
I'm trying.
He's trying.
I'm trying.
By the way, please, guys, do not, torture poor Tarek if he doesn't get to your questions. There's only so much time. We are going to start our webinar series probably next month.
Yeah,
right?
Sure, should be able to.
And that'll be private, little groups of like 50 people. We'll guarantee we'll answer several of your questions. It will be for pay. And we're probably going to figure out a model where we contribute some of those to a fund for helping people with their fertility. And the rest obviously will go to the cost of doing it. But we will have that coming up. So for those of you that are desperate to get your questions answered and you don't, there will be a webinar series where I will present a full topic and then we can answer your questions.
What diet is best during an FET cycle and after? A little confused, lots of conflicting POVs, gluten, meat, dairy.
There's no confusion on that. So the elimination diets are not good. There's actually one study we reviewed not that long ago which showed that dairy was beneficial. So you should not eliminate diet, and elimination diets, quite frankly, to me are impractical. I mean, if you're dairy allergic, you're gluten allergic, stay away. But for those who are not formally allergic, do not go off of gluten and dairy. That's silly. That's like saying all of Italy would never have children because they're eating nonstop gluten and all the pasta and bread and so on, right? Like it's absurd. It doesn't make any sense. So I'm not a believer in elimination diets. Having said that, things that you can do are the Mediterranean diet. So low red meat, more poultry and fish products, lots of fresh vegetables, lots of fresh fruits, stay away from sugary stuff, stay away from fats, a little bit of wholesome grains, nuts, that kind of thing. It's that bad.
I don't okay.
Apparently
It's
there are
very
10 million of you asking questions. Yeah.
Yeah, and I am.
And I got a pack for Scott.
I know you do. I know you do. It's one of those days.
What time is it?
Oh, you see, got a little bit more than 10 minutes.
Yeah.
You're cruising.
We're good. We're good.
You know what? For fun,
For fun.
we can attempt to do them rapid fire.
Okay, go.
Just so,
Oh.
let's just see if we can get through them. Because I don't think you can.
Challenge accepted.
All right.
Yeah.
If someone has endometrioma, is it safe to say they have endometriosis elsewhere?
Yes. Safe. Not 100% of the time, but almost always.
Is there multiple different treatments for PCOS, or are they generally all the same? Excited to get our results and start treatment next month.
There's 3 treatments for PCOS. Medical, which is letrozole or Clomid plus metformin if you have insulin resistance. Natural, which is things like the supplements, so NAC, inositol, coenzyme Q10, resveratrol, ALA. And then there are the lifestyle things, which are diet and exercise to get your body mass index down if you're non-thin PCOS.
How quickly can endometritis come back? Positive in March, took doxy, and then negative after repeat biopsy.
Immediately, because you may not have been adequately treated because you did a biopsy.
Love it. Thanks for the helpful info on the ERA.
Oh, good. I hate the ERA, by the way. I hate it. Yeah. If you didn't get that already.
Yeah, that's your passion.
Yeah.
Is metformin recommended for all patients with PCOS for egg retrieval?
No, only if you have insulin resistance or your body mass index is elevated.
What are your thoughts on embryo glue?
Awesome. We use it in every single case.
Nice. Does letrozole need to be used with Lupron for adeno downreg?
Hang on one second. So embryo glue is a 30% increase in your success. Initially, when we started using it, we were charging for it, but then we stopped because we realized it was like it should be mainstream, and we just blended it into the cost of what we were doing. So yeah, we use embryo glue for everybody now. You guys don't even know we do it, but we do it for everyone. Yes, you need letrozole for endo and adeno because Lupron alone has been shown to be useless. So you have to do Lupron with letrozole. Otherwise, you're not actually getting any benefit. This is good. I like the
I'm trying my best. Does letrozole need to be used with Lupron for adeno downreg? Yes. Thoughts on reproductive immunology after numerous failed euploids?
Definitely.
Any updates on the waiting list for microscopic surgery? I've been waiting since August. Oh, that's double. When you talked about success of the ERA test, the RE-ERA test, and at day 5 or 6, what is considered success in that situation?
Live birth.
Would it be a positive beta?
No, they were looking at live birth.
Why would I be diagnosed with PCOS at 35 after many specialists have followed me and didn't see it?
I diagnose people every day with stuff that other people did not see or diagnose. I've had people show up here with extremely abnormal uteri that no one told them about. We've had people show up here with endo that no one told them about. People that showed up here with horrible sperm that no one told them about. Like left, right, and center, I've had it all. Nonstop every day, we find stuff other people didn't know about. That's why our success rates are better. So yeah, all the time we figure stuff out. With all our immunological testing now, I mean, we just had a lady post the other day. I should have posted that. Maybe I did post that. Did I post the one with the lit? Yeah. She tried for 9 years. She never got pregnant. And then she got pregnant without even getting to the IVF because we did lit for her because that's what she needed. Actually, you know, it was super interesting today. I had a lady with a lifelong history of spontaneous, unexplained rashes. She would just break out in rashes all the time, like nonstop. So I did lit there before last month. Gone. Like she's not getting it anymore. No idea. I got no idea how that works.
That's magic.
Yeah, I know. It was cool.
That's unbelievable.
Very, very cool. So clearly her lit worked. I don't even need to test her.
That's crazy.
Yeah, I know. It was really wild.
Do you induce all your patients at 39 weeks or just IVF patients?
So if you look at the Society for Maternal Fetal Medicine recommendations now, which we definitely, you know what, we got to do that as a show.
Which one?
Society for Maternal Fetal Medicine recommendations for IVF pregnancies. So if you look at those recommendations, they do recommend it, but the ARRIVE trial had nothing to do with IVF patients. It was just all women. And they clearly demonstrated, and we have a great video on this on our YouTube channel, that induction of labor at 39 weeks is safer for primips who are, planning to deliver a baby. It's safer than waiting for expectant management. So I offer an induction of labor to all of my patients at 39 weeks, but I mean, obviously I can't insist on it, but I come as close as I can to insisting on it with my IVF patients because waiting longer has zero benefit. That's proven, and has substantial risks of stillbirth, loss, hypertension, cesarean section, all of which are negatives that we don't want our patients to experience.
I don't even know where to look.
I thought we were doing good with the rapid fire.
You can try. Do you recommend Valicite?
Yeah, you asked that one.
Oh, great. Success of 7-day euploid embryos.
You asked that one too.
Oh,
Day 7 euploid,
yeah.
15%.
5 euploid embryos.
Yeah,
1 bladed oval.
yeah,
1 miscarriage at 12 weeks.
yeah.
1 beautiful baby girl.
Okay,
Modified natural.
yeah,
15 milligrams pred. 5,000 IUs of fragment.
okay.
Just saying, I guess. There's nothing else there.
Cool. Good protocol. I like it.
What is the average success rate at 43 and how many cycles approximately?
It depends on a million factors. So it depends on a lot about you and the sperm quality, body mass index, how strong are your ovaries, is your AMH 20 picomoles per liter or is it 2 picomoles per liter? So there's no way to answer those questions. I need to know way more about you. If you look at Carter data or SART-CORS data, you're looking on average around 8 to 12% for that age group. But I can tell you we do way, way, way better than that, like almost 4 times higher than that. So, every clinic is different.
Do you drink teas that have caffeine or decaffeinated tea?
I drink both, but I generally only drink green, herbal, jasmine, mint, or these fruity, peachy. Tarek's drinking Tetley tropical blend, and I'm drinking ginger, peach, something or other. I think also from Tetley, although I'm not sure. It's really good though. I like that tea a lot.
So I don't know if we have time for this story or not. We probably don't, but I think it's a good story. I'm at the grocery store.
Oh, okay, yeah.
Pushing my cart.
Yeah.
With the wife. She's buying whatever she thinks she needs. I'm buying whatever I think I need. Every once in a while when she's not looking, I throw something out. That's how we save money at the grocery store. I don't want to eat this. And I just whip it out.
Does your wife ever watch this show?
I'd be really outed.
You're burned, man.
Yeah. No, she's got kids. She's not watching anything. Yeah, so throw things out left and right. And then as we're putting the food on the conveyor belt or whatever it is, she sees a bunch of these little Tetley teas.
Oh, yeah.
She's like, who drinks these flavorful teas? I'm like, what? She's like, what's wrong with black tea? I'm like, nothing. Black tea is good. She's like, what about Indian tea? Because we buy like that chai tea as well.
Yeah.
She's like, what's wrong with that? I'm like, nothing. She's like, what's this? And she's just reading them, like, in my opinion, in a loud voice. Blueberry this and, and I just felt like she was like, somehow.
She was putting your tea down.
She was putting the tea down. That's right. I'm like, well, I like them, and there's nothing shameful about it.
Sounds like she was questioning your manhood.
I really felt it. To be honest. I really felt it. Like, I felt I needed to just drink raw caffeine after that.
Hey, I feel very much a man, and I love my peach ginger tea.
So then my kids...
It's Epicurean.
So my kids saw it.
Way, yeah.
And they're like, oh, can we try that peach treat? That peach tea? I'm like, yeah. And then my wife will see, even the kids like that. Is it really tea? Is it really tea?
Hilarious.
Yeah, that's the day in the life of. Continuing on. Thoughts on cold plunges? Any issues with cold exposure and fertility?
I've never seen, that's a great question. I've never seen any changes between cold plunges or any associations between cold plunges and fertility. We do know that 30 seconds to 2 minutes of a cold plunge raises your dopamine levels for 2 hours more than doing lines of cocaine does. And cocaine is very short-lived for the rush in your dopamine levels. The cold plunge lasts for like 2 hours. So there are huge benefits in inflammatory tendencies, There are huge benefits for your overall well-being. It's very good for depression, anxiety, stress. It's good for your joints, for your muscles. There's a whole bucket load, pardon the pun, of benefits for cold plunges. So if you can tolerate the plunge, go for it. I'm actually thinking of buying one for the cottage,
What?
a cold plunge.
Really?
Right
You would
next
do
to
it?
right next to the hot tub. Oh yeah, it's great for you. Right next to the hot tub. So you're supposed to go in a sauna
Yeah.
and then
And
get
then
out of the sauna and jump into the cold plunge because otherwise it's like brutal, right?
I feel like your skin would like break off in pieces.
No, my kids did it last year. They were in, or 2 years ago. I don't remember what, 2 or 3 years ago. They were in the hot tub and then they got out and they ran and just lay down in the snow and then they ran back in the hot tub.
Really?
Yeah, it was pretty funny.
Courageous human
Yeah,
beings.
yeah.
Cold plunge. Makes me freezing.
Tark's shivering off to the side here, and the room's actually quite
Yeah,
warm.
it's warm, but you not made for that. Do you have to be on an injectable blood thinner if homozygous for PAI 4G slash 4G?
Have
Can
to
you just
be,
take
no.
aspirin
Should you
instead?
be? Yes.
Okay. What's better for endo downreg, Orilissa or Lupron Depot and Letrozole?
Lupron Depot and Letrozole. There's no evidence that Orilissa works.
Okay. What investigations would you recommend for someone with adenomyosis and endometriosis with multiple embryo transfer failures?
Fertility testing, thrombophilia screen, vitamin levels, sperm DNA fragmentation, saline infusion sonohystogram, endo excision or ablation, and then an endo protocol. So we put out our endo protocol recently. That's on YouTube, right? The endo
Yeah.
protocol. So check out our endo protocol on our YouTube channel. Half my time these days is actually spent sharing our typed up endo protocol with people from all over the world.
Really?
Yeah, because no one's doing it. But now it's like out there.
It's out there.
I think it's going to be like out there soon.
It's like when the Big Mac sauce is revealed.
Yeah.
Recent articles in the US came out about a clinic using OBGYNs for
Yeah.
procedures.
Yeah.
Thoughts?
I have no problem with anybody. It doesn't even have to be an OBGYN. It could be a PA or, in theory, a nurse practitioner doing egg retrievals and embryo transfers. There is nothing unique about doing an egg retrieval or an embryo transfer. It does not require a brainiac. It's like saying, I had this discussion online with someone the other day. It's exactly like saying that I should do all ultrasounds because an ultrasound tech isn't qualified to do an ultrasound. No, of course not. If you train them and you teach them what to do and how to do it, it's not something where they need to interpret something. They're just sucking out eggs. It's like shooting fish in a barrel. It is not a difficult thing to do. Sure, there are some cases that are harder, and maybe not every case should be done by someone that's a fellowship trained individual. But the argument that only REs should do egg retrievals is asinine. It's stupid. First of all, there aren't enough REs to do the egg retrievals. Plain and simple. You guys are all going to be waiting, and there's compromises in waiting if some of you are waiting too long. So number one, it's just not doable. Number two, I could train a monkey to do an egg retrieval. It's not rocket science, or an embryo transfer. Sure, like I said, some of them are difficult, but by and large, it's not that hard. Tarek watched an egg retrieval, and Tarek, said he thought he could do it, which I did chuckle at, but nevertheless,
if a monkey could do it, I know for
think you
sure I could do it.
with some training.
With some training.
Right,
Absolutely.
right. You thought you could do it right away.
Yeah. I'm a little bit eager.
A little eager.
Yeah.
And the reality is, years ago, I'll give you the best example, okay? Years ago, way back in the early days, I had the opportunity to be present at a time when someone who has absolutely no medical training whatsoever was standing next to me while I was doing all the ultrasounds, taking down the numbers. And eventually I looked at them and I said, because I could tell from the look in their eye that they could do this without me even teaching them. And I said, you could probably do this, couldn't you? And they looked at me and they went, yeah. Because they just watched me do it so many times, they knew what to do. So there's absolutely no argument that is valid for saying that a non-RE should not be doing an egg retrieval or an embryo transfer. It's a technical thing. Anybody can be trained to do that. If you can train midwives to deliver babies, why can't you train people to do egg retrieval? And especially, why can you not train an OBGYN or a physician assistant to do egg retrievals and embryo transfers? It's ridiculous. So I have absolutely no belief that that makes any sense whatsoever. That is designed to protect the little guys like me, in terms of business size, from the big companies that have so much volume that they can't support it with the number of REs that they have. So they're trying to hire non-REs to do their egg retrievals and embryo transfers. Like, you don't need to be an RE. It's fine. It's an egg retrieval. Like, it's not rocket science. When you're doing residency, some residency programs let you do it. So why wouldn't we let the OBGYNs do it when they actually have the skills and so on? Or for that matter, an ultrasound technologist. If a physician assistant, here's an even better example. If a physician assistant can do a kidney biopsy, they can sure as hell do an embryo transfer.
I think so.
Yeah.
9:05.
What do you want to do?
I'm just letting you know.
5 minutes?
I'm just telling you the time.
5
That's all I'm
5
doing.
minutes.
I'm just letting you know.
In my defense, I stayed up late and I am half packed.
Hey, you need to finish the other half of that packing.
And then I managed to trap the kitten in the room with me. And then,
nice.
And then he wanted to stay with me and snuggle, so he was really cute.
Nothing wrong with that.
I love my kitty.
Is a slight heart shape okay? Sonal said under 1 centimeter.
Oh, it depends on how under 1 centimeter it is and how many previous miscarriages, failures, blighted ovums, whatever you've had. So I can't answer that without knowing more about you. And it depends on what you're doing. You're doing IUI or trying naturally, sure, go ahead. You're doing IVF and you've already failed once, no, fix it.
Hey there, have had cycle day 3 labs and I'm going to be 44 next month. My FSH today was 12.3, freaking out, 1 successful pregnancy, 2 miscarriages after that. Any idea why? Should I do fertility treatments?
Well, I can tell you the why of the miscarriage. You're 44. So your risk of having a miscarriage is about 60% each time you get pregnant, 50 to 60%. As for should you do fertility treatment, that's completely up to you. I never push people into treatment. It would certainly be reasonable to do what you're doing, which is seeking, investigations. FSH of 12.3, that's an elevated FSH. So it's entirely possible that your ovaries are becoming weaker.
How important is blood sugar regulation during TTC? My friend is skipping her metformin.
Extraordinarily important. Poor hemoglobin A1C is associated with brain and cardiac defects in infants.
Mm-hmm. So somebody in the group, in the group that isn't taking it, so then they just got outed now.
Oh, whoops. Yeah.
Best doctor ever. We are forever grateful for you, Dr. Victory. Our twins just turned 6.
Oh my God, that's so cool. Who's that?
That is from Amber.
Oh, hey, awesome. Glad you're doing well.
Dosage of progesterone in the first try.
It depends on your history and what you're doing. So IUI, we use 203 times a day for prometrium, 2 crinone a day for crinone, and 1 endometrium 3 times a day for endometrium. That's for IUI. If you're doing IVF, it's PIO and one of those 3 again in those same doses. So it depends on what you're doing. And if you have endo, it's even more.
Hi, Dr. V and Mr. T. How soon after a consult with you does one start the IVF cycle?
Depends on what's wrong. I mean, I get people we can start very quickly if they come to me with recent testing. And then we've got other people where we need to do testing or we need to do fertility and I need to know what's wrong with them or even surgery. So again, anytime I hear someone say how soon, I automatically know they're probably not on the right track. Rushing your fertility is not beneficial for you. It's not because I want to slow you down. Believe me, I don't. Like, look, it's financially disadvantageous for us as a business to slow people down, right? This is not self-serving. And it's not because I don't work enough, because God knows, you all know I work insane hours nonstop every day. It's because you rushing makes you miss things, get less than optimal treatment, fail more, have to do more cycles. And I don't want that for you. I'm very much a one and done kind of guy. I want your first cycle to be successful so you don't have to come back for more.
Hello, I'm 35 and I've been trying to conceive for 3 years. Should I go with IUI plus gonal F, or should I not waste time and go with IVF right away?
I need to know way more information about you before I can answer that. There's no way. Just your age and what should I do? Don't tell me anything. I need to know the sperm quality or your BMI. I need to know your general health. What are your social habits? What have you done to try? How many times a week do you try? I spoke to a couple today. Well, the female. I did speak to the couple. She's having sex roughly once a month. They don't need, and they went to another fertility center who shall out of respect remain nameless. And that fertility center did IUI for them. They don't need IUI, they need sex. Like, it's insane. Why would they do that? You need to be aware of all the details of a patient before you tell them what to do. So that one drove me a little crazy today. That's today's.
I would have easily recommended that.
Yeah, like she's having sex. She goes, I have sex like maybe once a month. I'm like, okay, that's not going to work.
Of course, yes.
What time? 9:10?
PA here. I do lumbar punctures in the ER and multiple other procedures. I do believe fully we could be trained to do an embryo.
Hallelujah. There you go.
So do I, to be honest.
Yeah.
I believe they could too.
Yeah. There's no reason why a physician assistant or a qualified OBGYN should not do it. You know what? I will be happy to bring on. There was a debate about this at the Midwest Reproductive Symposium last year. There's no counterpoint to this. It's absurd to argue that a licensed OBGYN couldn't do it. First of all, before the development of REI, it was just a bunch of OBGYNs who learned how to do this. They didn't have special training. They watched someone do it and then they did it. I learned how to do laparoscopic subtotal hysterectomies by watching Ted Anderson in Nashville, Tennessee. He showed us all how to do it. I was just standing around in the room. I was like, well, I can do that. I came back, I did it, and I was fine. Like, I did a bunch of them. So you don't need to get like all this expertise. If you're good at what you do, or you can be trained to do what you need to do, that's what it's all about. That's how X-ray techs become X-ray techs. That's how, people that do ultrasound become ultrasound techs. That's how people that do blood draws become phlebotomists. Like, doctors aren't needed, or specialty training is not needed for every single one of these things. No one ever taught me how to draw blood. I do it all the time. Literally, did you know that? Never got taught how to draw blood. I draw blood all the time. Never once did anyone show me how to do a intramuscular or subcutaneous injection. I do them all the time. It's not like we get trained for that. It's idiot proof. So even if it's not idiot proof,
maybe I should try these things out.
Yeah.
Just walk back here, put on a lab coat, and start.
Dude, no one's even ever seen you. I don't think they're gonna let you start doing stuff.
Put me in a lab coat. They'll let me do anything.
So I mean, you don't need specialty training for all this stuff. I'm gonna rail against that, and I'll forever argue. I actually saw that this morning and yesterday, because it was a Society of REI message that came out, SREI message that came out. Yeah, it's stupid. It's like absolutely stupid. It's a job protection thing. You can't validate that argument. There's no way.
9:12.
Yeah, we're done.
I'll go with one last question, just because I find this might be a good conversation.
Yeah, and did we answer all of Carly's stuff?
Carly specifically.
Make sure you addressed any Carly question before I get an earful.
Serious preferential treatment here. I heard drinking hot beverages causes esophageal cancer. I never checked to be sure.
That's true.
Really?
Yeah. Did you know that Iran, my hometown, has the highest rate of oropharyngeal cancers in the world because they drink their tea so hot?
Really?
Yeah.
Oh, interesting.
I was just yelling at my wife and kids about that the other day. I said, you guys got to stop drinking your tea so hot. And they're half white. Well, she's all white. The kids are half white. Yeah.
Really?
Yeah. My white kids and wife drink their tea way hotter than I do.
How hot do they drink it?
Hot.
Really?
Like I'll burn if I drink it at that
Really?
temperature. Yeah. It's idiotic.
I like the temperature here that we got.
Why would you do it?
This is the temperature.
Yeah.
So you ready for the question?
Okay.
All right.
I thought that was the question.
No, that was just a Carly question. Now they're done. Everyone's commenting, wow, VIP. Everybody's like,
She's probably on cloud nine.
This is a naive question.
Okay.
But
yeah,
if REs aren't doing procedures,
yeah,
what are they doing and what are we paying for?
The technical part is easy. I mean, I'm not saying it doesn't benefit having one of us there. In some cases it does, in some cases it doesn't. But what it is good for is the thinking part, the learning part, the educating part, the communicating part, the consoling part, the protocol part, the monitoring the lab part, the running the business part, the trying to drive the prices down part, the trying out new equipment part, all of those things. That's all us. I got to be aware of all the information. I got to go to the conferences. I got to educate myself constantly. I read 6 different journals every single day for you guys so that I stay at the cutting edge. That kind of thing, you're not going to teach an ultrasound tech to do. They're not going to do that. That's all me. And I got to be educated and motivated enough to be able to make sure that I want my whole team to be operating seamlessly. That's not a technician's job. That's what you're paying for.
It's like saying
that
if you weren't you, then you would be recommending the ERA test.
I like that. That's very good. That's
right?
very good. Yeah,
that's
very good. Yes, right? Yeah. So that's actually, you know what? That's freaking brilliant.
That's pretty good, right?
Good job, T. So yeah. So basically, you know, if I wasn't doing what I was doing, I'd probably recommend the ERA test like everybody else does. But the ERA test is useless, and I know that because I read every study on ERA. So yeah, like that's what you're paying for. You're not paying for an egg retrieval. A monkey could do an egg retrieval. It's really very, very, very easy. You don't need a technician, a physician to do an egg retrieval. We good?
It's the experience.
It's the experience. Yeah.
Absolutely.
Yeah. Okay. I love you all. That was a good show. That was a really fun show. That was a good show. Please don't out Tarek to his wife about throwing the stuff out of the grocery bag. You guys have a lovely evening. Wish me luck in Scotland. Hopefully I'll get some sleep on the flight. And I hope you guys have a wonderful, wonderful week. We will be back next week. We are, right? Next week? Yeah, next week we'll be back. And maybe we'll do, let's do you know what? If we advertise and promote that now, that would be good. Let's do the review of IVF pregnancy recommendations. Tons of people will clue in for that. And then we can just put that up as a YouTube video.
Okay.
Cool. We're going to review IVF pregnancies next week. Have a good day. Have a good evening. And love you all. Don't forget to like, comment, and subscribe. And thanks for all the support. We love you all. Have a good night.